This is video number 2 about acid-base disorders, and this is Dr. Kemal. In the first video, we talked about the respiratory conditions, whether respiratory acidosis or respiratory alkalosis. In this second part, we'll talk about the metabolic disorders between metabolic acidosis and metabolic alkalosis. So we'll start first with metabolic acidosis, but before we go through metabolic acidosis, I just want to talk briefly about anion gap. Again, I'm sure you know that pretty well that when we talk about metabolic acidosis, the first thing we need to look for the anion gap to see if it's a normal anion gap, if it's between 8 and 12, or it's a high anion gap metabolic acidosis, because the etiologies are so different, right? But let's understand what is an ion gap actually. What is an ion gap? So you have to know that our body is electrically neutral, which means the total cations, the positive particles in our body, equals the total of the anions, which is the negative particles in our body. Um, and when it comes to cations or anions, there is usually measured cations and measured anions, and unmeasured cations and unmeasured anions. So, for example, if we look here, the total cations and the total anions will be the same, but what we can measure is not the same. For example, when we come to the cation, the most important cation in our body is the sodium. And the sodium we can measure, and the average normal is 140. But also we have a lot of unmeasured cations that we usually don't worry about because we don't want to chase every single one of them, between magnesium, between calcium, between potassium, between some proteins. On the other side, the anions, we have the measured anions and the unmeasured anions. The measured will be mainly the bicarb and will be mainly the chloride, while the unmeasured anions will be phosphate, sulfate, and albumin, right? And albumin is really important here. I'll talk about it in a little bit. And usually, as I said, we have the total cations equals the total anions, but the problem is the unmeasured anions is more than the unmeasured cations. And the measured cation, which is the sodium, is more than the measured anion, which is the bicarb and chloride. So, for example, if you have normal sodium, level, the normal sodium level is around 140, right? The normal bicarb level is about 24. The normal chloride level is around 104. So if we add those together, 104 and 24, it will be 128, right? So 140 minus 128 is around 12, which is the gap. So this is the gap. So when we say we have a 9 gap, that means there is a gap which is 8 to 12 points that we cannot measure um, in the anion phase. And that's what we call again the anion gap. So that doesn't mean our body has more anions. No, it's electrically neutral, so the cations equal the anion, but it's all about measured and unmeasured. Just because the unmeasured anions are more than the unmeasured cations, we have this specific gap, right? So this is normal, right? The normal gap is between 8 and 12. And this again makes sense if you take the normal ranges and you subtract the 128 from the 140, it will be around 12. Getting back to the metabolic acidosis, we talked about the anion gap. We now understand what is an anion gap and why it's normal. So if you have metabolic acidosis, and you calculate the anion gap, you find the anion gap between 8 and 12 that we call normal anion gap. If the anion gap is more than 12, that means it's high anion gap metabolic acidosis. So let's first talk about the normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis is usually because of bicarb loss. And this bicarb loss, it can be renal loss or GI loss. We'll talk about it. And what happens here that you have again, this is the anion column that we talked about here, right? That's the anion column. So what happens here in the metabolic acidosis, you have decrease in the bicarb. So as a compensation to keep the anion number equal or equivalent to the cations, what happens as a compensation, you decrease the bicarb, so you increase the body, increase the chloride instead. So here, if you have the bicarb at this much and the bicarb decreased here, what happen will be increasing the chloride. So the chloride will increase from this small part to this bigger part, but the whole thing is the same as here. So you still have the same gap. Why? Because yes, you decrease the HCO3, but on the other side, as a compensation, you increase the chloride. So you kept the same gap. While on the other side, if we talk about high anion gap metabolic acidosis, it's usually addition of an acid. And acids are anions, they are negative charge, right? So here you didn't change anything. The bicarb is here, the chloride is here, but you added something here. You added an acid here. So this acid increased the unmeasured anions and therefore increased the gap. That's why you have a gap more than 12. And usually we'll talk about this in details, but usually this acid, it can be intrinsic acid or extrinsic. Intrinsic, like lactic acidosis or ketones. Extrinsic can be drugs like salicylate or iron, or it can be different types of alcohol, right? So this is a really important introduction about metabolic acidosis to be able to understand what's coming next. So let's start. Metabolic acidosis, again, if we are talking about acidosis, then we know the pH is less than 7.35. And we are talking about metabolic, we know the problem is in the bicarb. The bicarb is low. And the first question I wanna, and there's a particular algorithm you have to follow if you have metabolic acidosis. Number one, the anion gap. We need to know if this is normal anion gap or it's a high anion gap. Why? Because the causes are different. And again, it's all about the cause. It's all about the etiology. We want to know what the etiology of the disorder. And the way we calculate the anion gap, it will be the sodium minus the combination of the anions, which will be the chloride and the bicarb. And if you have between 8 and 12, that's normal. If it's above 12, then it's high anion gap. Only if, only, only if the anion gap is high, we calculate something delta ratio. And the reason we calculate it is to find if there's other metabolic disorder. Sometimes you have high anion gap metabolic acidosis, but you can have normal anion gap with it, or you can have metabolic alkalosis with it that we call mixed metabolic disorder. And the third step, if you are having metabolic acidosis, is to check for compensation. What the compensation? It will be respiratory alkalosis. And the way to look for the compensation will be Winter's formula, which we'll talk about. So again, if you're having metabolic acidosis, question number one, is it normal anion gap or high anion gap? And if it's high anion gap, you need to calculate the delta ratio to see if there's another metabolic disorder that's concurrent. And the third step will be the compensation. Sometimes the normal anion gap, we call it hyperchloremic metabolic acidosis. And why? Again, when we talked about the normal anion gap metabolic acidosis, we said there's bicarb loss. So this is the main issue, bicarb loss. And you are having bicarb loss, whether in the GI or in the kidney, the compensation will be increase in the chloride. So you keep this ratio constant. So you decrease one part of this, you increase the other part to keep the normal or the total anion at the same range. So that's why we call it sometimes hyperchloremic. So if we want to check for the compensation, it will be respiratory. What kind of respiratory compensation? You will increase the CO2. So if you decrease the bicarb, the compensation will be to increase the PCO2, decrease the PCO2 to, again, PCO2 is an acid, so you want to get rid of it to decrease the acidity. So the expected PCO2, how much the PCO2 should drop to compensate for the drop in the bicarb. Here's come the Winter's formula. And Winter's formula is 1.5 multiply the bicarb, let's say it's 14, 15, 18, whatever, it will be low. Why? Because it's metabolic acidosis, so the bicarb number will be low. And after that, you add 8 to that equation, and you give it a range plus or minus 2. So here we calculate the expected PaCO2. If it's within this normal range, then it's compensated. If the PCO2 more than the range, that means you're having metabolic acidosis, but also you have respiratory acidosis, so it's mixed disorder. Or if the PCO2 is less than the expected compensated, then you have respiratory um, alkalosis. Just as an example, let's say you use the Winter's formula and you calculate the expected PCO2, and you calculate it from this equation and you find the expected PCO2 to be, let's say, 30, okay? And you do a VBG, and the VBG shows the PCO2 is 31, right? 31 is within the range because we said there is plus or minus 2, so it should be anywhere between 28 to 32. So here's 31. That means there is proper compensation. But let's say instead of 31, you have 35. That means the CO2 is high enough to have respiratory acidosis. So here you have respiratory acidosis and metabolic acidosis. Let's say you do a VPG and you find the PaCO2, and instead of 31 or 35, you found it 25. That means you're having respiratory alkalosis, right? So this is number one, the compensation. We used Winter's formula. What is the question we're asking with the Winter's formula? Is there appropriate respiratory compensation, or there is respiratory acidosis or respiratory alkalosis beside the metabolic acidosis here? And this Winter's formula, it works for both normal anion gap and high anion gap metabolic acidosis. So that's number one. Number two, we calculated the anion gap and we know exactly it's normal. So how we calculated that? So the anion gap will be the cations minus the anions. The cations, which will be the sodium, minus the anions, which is the total or the chloride and the bicarb added together. And the normal range will be 8 to 12. Sometimes you need to correct for albumin, correct the anion gap for albumin. Again, if you remember when we talked here about the anions in our body, we talked about measured anions, which is the chloride and the bicarb, and there's the unmeasured anions, which phosphate, sulfate, but also the albumin. And here we are just um, uh, estimating or considering the albumin is normal, which is 4. But let's say someone is having albumin of 2 and they having a anion gap of 12. So that means probably their anion gap is higher than 12. Why? Because their albumin is low. So there is less unmeasured albumin. So how to correct albumin for anion gap or correct anion gap for albumin? You usually do the following. For each 1 drop in albumin, 1 drop in albumin, you increase the anion gap by 2.5. So in this example, the albumin is 2, right? So the albumin is 2 points less than normal because 4 minus 2 equals 2. And for each decrease in 1 of albumin, you increase the anion gap by 2.5. So 2.5 multiplied 2 will be 5, and you add this 5 to 12, so the actual anion gap here is 17. So look, this is tricky because here you can misdiagnose this patient. You calculate the anion gap, you find it 12 or you find it 11, and you say, oh, it's normal anion gap metabolic acidosis, but actually if you correct it for the albumin, you'll find it's elevated. So you need to um, correct the anion gap for the albumin. Then um, when we talked about metabolic acidosis with normal anion gap, we said it's usually bicarb loss. Bicarb loss, it can be bicarb loss in the kidney, like renal tubular acidosis kind of cases, or it can be in GI if someone having, fistula or they having diarrhea or different etiologies in the GI and the renal we'll talk about. So we need to differentiate, is it a renal problem or GI problem? And here comes another thing, which is called urine anion gap. And urine anion gap, it answers the question, is it kidney problem or GI problem, right? So if you calculate the urine anion gap and you find it negative, that means the kidney is acidifying normally. That means it's not kidney issue. That means it's a GI issue. If it's positive urine anion gap, that means the kidney is not working good enough. That means it's a kidney problem rather than GI problem. And how does this make sense? So let's imagine we said metabolic acidosis, it's a problem in the HCO3, right? And you have acidosis. So what the kidney will try to do is correct the acidosis. How to correct the acidosis? You try to increase hydrogen secretion. And what the buffer for hydrogen is usually the ammonia. So you cannot secrete hydrogen ion by itself, so you add it to NH3 and you form NH4, which is the ammonium. So the way the kidney excretes the excess hydrogen ion is to excrete it in form of NH4. So NH4 is the proxy for renal acid secretion. But the problem here is you cannot really calculate the NH4 in the urine easily. So we use the urine chloride instead, because usually when you secrete the NH4 take chloride with it. So if you're having increase in the chloride excretion, that means you're having increase in the bicarb excretion. That means you are excreting more hydrogen ions to correct for the acidosis. That means you are having working kidney. So here, again, if you're having negative urine anion gap, that means you are excreting chloride a lot. And if you are excreting chloride, that's an indication you are excreting NH4, and NH4 is just the buffer for hydrogen ions. So that means the kidney is trying to acidify or excrete the hydrogen to compensate for the acidosis. That means that the kidney is good, the kidney is working fine. That means it's a GI cause. On the other side, if it's positive, urine anion gap, that means you are not excreting a lot of urine chloride, right? that means the NH4 is not a lot. That means the kidney is not trying to get rid of the hydrogen ion. That means the kidney is not doing its job, because if you have acidosis, the kidney compensate for it by excreting the hydrogen ions, which is an acid, to decrease the severity of the acidosis. So if you have positive UAG, that means it's a kidney problem, whether renal tuber acidosis or renal insufficiency. Okay, then again, let's recap. We have a metabolic acidosis, pH less than 7.35. We look at the HCO3, the HCO3 is like 18, so it's low. So we know it's metabolic acidosis. The first question, is it an ion gap, high anion gap, or normal anion gap? We measure the anion gap and it's, let's say 9 or 10. So it's normal anion gap metabolic acidosis. The problem is in the HCO3. You are losing HCO3, whether in the kidney or whether in the GI. Which one? We calculate the urine anion gap. The urine anion gap, if it's negative, then it's a GI cause. If it's a positive, then it's a renal cause. Okay, now we know it's a renal cause, right? Sorry, now we know it's a GI cause because we have negative UAG. So negative UAG, we know the GI losing a lot of carb, or sometimes it's exogenous, which we'll talk about what exogenous means in a minute. So, different scenarios that can be causing the GI to lose the bicarb. First, the diarrhea, which is the most common cause of metabolic acidosis with normal anion gap. And here, you having direct loss of the bicarb, which is existing in the intestinal fluid, right? Key clues for this, sometimes from the history, volume depletion, sometimes hypokalemia as well, because if you are losing bicarb, usually you are losing potassium with it. And the treatment here is you are trying to avoid the diarrhea. Sometimes you need to replace the potassium to give IV fluid, etc. Second cause, and this is a GI cause as well, could be pancreatic or biliary fistula or drain. And here again, you are losing biliary acid, which is bicarb rich. So you need to get like good surgical history if the having drain. Sometimes this drain can be draining too much. So sometimes you need surgical consultation or try to decrease the output from the fistula or the drain. Again, the same concept, ileostomy or sigmoidostomy, that's GI bicarb loss. Again, surgical history and to correct whatever electrolyte abnormalities they have. This is really interesting. Remember when we said the normal gap, a metabolic acidosis, we call it hyperchloremic. Sometimes it's not bicarb problem, sometimes it's chloride problem. So in all these scenarios, we said it's the bicarb is decreasing, and response to decrease in the bicarb, you increase the chloride to keep the total anion number stable or constant. Sometimes it's just the opposite. What I mean by that, you give normal saline, and the normal saline, it has a lot of sodium, but it has a lot of chloride as well. So if you are giving someone normal saline, you are giving them a lot of chloride. So you are giving them a lot of chloride. What will be the response? Decrease in the bicarb in response to increasing the chloride. So here it's the opposite. So sometimes if you are resuscitating someone with large volume normal saline which has chloride, what will happen is hyperchloremia, and that will decrease the bicarb. First, it's dilutional, but also to keep the total anion constant. And here, close to this, recent IV fluid therapy, sometimes we see this in the DKA because NS or normal saline is still the preferred IV fluid for DKA. So sometimes we see it in DKA. And in that case, you will see high chloride as well. And what do? You just switch the IV fluid. So if you are using normal saline, you can switch to another balanced crystalloid like LR or plasmalite. Another When we talked about GI loss, we said also exogenous, and what we mean by exogenous, something from outside, like acetazolamide. So acetazolamide, it inhibits the carbonic anhydrase enzyme. And what does carbonic anhydrase do? Carbonic anhydrase help in the bicarb absorption. So if you are inhibiting that enzyme, you are losing bicarb. And here the kidney is fine. So it's not kidney problem. It's not renal insufficiency. It's not renal tuberoacidosis. It's just a medication that I'm giving exogenously that's inhibiting the bicarb absorption. And this usually acetazolamide is not as common now, but sometimes it's given in glaucoma or high altitude or all that. And those patients, sometimes you can give them oral bicarb. Another thing is the ammonium chloride ingestion, which we don't see as much, but again, that's exogenous acid load. So it's ammonium, so NH4, so NH4, it's NH3 and hydrogen ion. So here it's you are adding hydrogen ion, which is an acid, so you are causing metabolic acidosis. So you can, consider toxicology or substance use history. And this is usually the treatment supportive care and hydration. But again, this is less common. I have never seen this before. So usually the most common cause will be the diarrhea. Then the other part is the renal cause. So again, we have metabolic acidosis, pH less than 73.5. It's metabolic, so the bicarb is low. And if it's normal anion gap, then we said it's usually HCO3 loss, whether in the kidney or GI. If and how to differentiate, we calculate the urine anion gap. If the urine anion gap is negative, then it's GI loss. If the urine anion gap is positive, then it's renal loss, right? And when we talk about renal loss, we have the renal tubular acidosis. So renal tubular acidosis, renal is coming from the kidney, so it's a kidney problem. Tubular, so you have a problem in the tubule, whether it's the distal tubules or the proximal tubules or different parts of the distal tubules, but for different reason, which is the hypoaldo problem. So again, it's kidney problem in the tubule that's causing acidosis, and this acidosis is normal anion gap metabolic acidosis. Because when we talk about AKI and uremia, we'll learn that uremia cause high anion gap metabolic acidosis. So not any kidney issue will cause normal anion or high anion gap metabolic acidosis. It depends what is the etiology of the kidney problem. So if it's renal tuber acidosis or RTA shortly, it will cause normal anion gap metabolic acidosis. This is a nice summary. You can look at it, the different types of the renal tuber acidosis. I will not go through them in detail just for the sake of time, but mainly we have three types of renal tuber acidosis: type 1, type 2, and type 4. Type 1, it's a distal tubule problem. And if you remember from physiology, one of the um, functions of the distal tubule is to secrete hydrogen ion. So if you have the distal tubule diseased and not able to secrete this hydrogen ion, you are retaining this hydrogen ion, causing renal tuber acidosis. While number 2 or type 2, which is the proximal tubule issue, another name, proximal renal tuber acidosis, you are not able to reabsorb the bicarb in the proximal tubule. So here you are losing bicarb in the kidney, right? And this is more rare. Then type 4, it's mainly a problem in the it's a problem in the aldosterone, so hypoaldosteronism. Whether you have aldosterone deficiency or you have enough aldosterone, but there's resistance at the level of the aldosterone receptor. And here if one of the functions of the aldosterone is to secrete the hydrogen ion and the potassium. So if you have whether aldosterone deficiency or aldosterone resistance, you are not able to secrete the hydrogen ion and you are not able to secrete the potassium. So you are retaining both hydrogen ion and potassium. By retaining the hydrogen ion, you are causing the acidosis part, and by retaining the potassium, you are causing hyperkalemia. And this is really important because if you look on the different causes of the normal anion gap, metabolic acidosis, you will find hypokalemia, whether it's type 1 RTA, type 2 RTA. So here's low potassium, here's low potassium. But also remember in the diarrhea part, usually it comes with hypokalemia also because when you're losing bicarb, you're losing hypokalemia, you're losing potassium, causing hypokalemia. But this is very special. Type 4 RTA, you're having hyperkalemia, not hypokalemia, again, because you're not able to secrete the hydrogen and the potassium, so are retaining both. Here is different etiologies of it and treatment. We'll talk about this in another situation. So by now, we are talked about the metabolic acidosis, the normal anion gap. In the next video, we'll talk about the metabolic acidosis, but with elevated anion gap.